Lateral to that, just here, is the supraorbital. So we have supratrochlear, supraorbital, and they pierce the corrugator muscle. As we look at this corrugator muscle, we see it emanating from bone just inferior to the prominence on the frontal bone, the orbital ridge. If we take the frontalis muscle and move it back, we see other medial depressors of the eyebrow. In the midline, we have the procerus muscle. Just lateral to the midline, we have the depressor supercilious muscle. And there's always a little gap between them, a little space between this vertically oriented procerus muscle and the relatively vertical depressor supercilii muscle. In this space, we have the deep fat pad of the lateral radix, called the lateral radix fat pad of the nose. In this space, where there is no muscle, we have vessels that are exposed, which can cause us to have occlusion of these vessels if we're doing a liquid injection type of rhinoplasty. Again, if we peel back the frontalis muscle and we look at the corrugator muscle, we can dissect laterally where we're seeing the deep fat pad of the brow and inferior forehead. This is called the roof or retroorbicularis oculi fat pad. If we dissect slightly more inferior to this, we can dissect and cut through the inferior periosteal attachment to the superior orbital rim. The superior orbital rim is shown right here. The periosteum of the frontalis muscle is here, and we can cut through this. The edge of the frontalis periosteum, the frontal periosteum, is known as the arcus marginalis. And if we cut into that and use the scissors to spread into this area, we will see the fat of the roof of the orbit. And we're going into the orbit through the arcus marginalis into the fat of the roof of the orbit. It is important to differentiate between these two different terms. The fat of the inferior forehead and lateral brow is superior to the orbital rim. This is called the roof or retroorbicularis oculi fat. The fat within the orbit is the fat of the roof of the orbit. So the roof fat and the fat of the roof of the orbit are different. Both deep fat pads, one within the orbit, one outside of the orbit. At its head, we use a deep injection almost down onto the bone. If we're injecting the tail of the muscle, out here, this is a more superficial injection as this muscle orients from deep medially to superficial laterally. So injection at the club head should be deep, injection at the tail should be superficial. If we inject centrally into the procerus muscle, this is a vertically oriented muscle which attaches from soft tissue to soft tissue to the soft tissue and fascia overlying the upper lateral cartilages and the middle of the nose. And we would inject this here into the mid-level structures of the nose. The third injection here can be done into the depressor supercilious muscle. The procerus muscle and the depressor supercilii muscle are both superficial to the corrugator supercilii muscle. This is a more vertically oriented muscle. This is a more obliquely oriented muscle. All these are depressors of the medial eyebrow. So we're going to talk about nasal anatomy specifically as the anatomy relates to injections. Injections of both botulinum toxin and to filler. Obviously, the filler complications can be more devastating, causing either tissue necrosis or blindness. But we'll first talk about botulinum toxin in the nose. There are various orientation of rhytids around the nose. We call them bunny lines, but the bunny lines can have a variety of orientations. If the orientation of the bunny line is primarily a horizontal one, it can be from the LSAN, the levator labii superioris aliquinasi, which is a muscle that goes along the side of the nose and wraps around the nose. It can elevate the upper lip and it can create some of these rhytids. If the rhytid is more vertically oriented, it is usually from the transversalis, one of the heads of the transversalis muscle that is out here. There is a muscle called the animalis muscle, which is located in here. We cannot see it right now because it's been taken out in this dissection. And that's usually responsible for more diffusely oriented rhytids, which are not either vertical or horizontal, but can be a mixture of both. So any one of these three muscles, the levator labii superioris aliquinasi, the transversalis, or the animalis muscle, can be responsible for rhytids and bunny lines around the nose. And how you inject that individual is based on the rhytids that you see, trying to get rid of them. Usually it's a relatively small injection of botulinum toxin in this area. Next, I'm going to talk about filler injection. And this is a little more complex because certainly we want to create the improvement in contour in the nose with this, quote, injection rhinoplasty, and we want to avoid complications. So the first is to look at the aesthetics of the nose. What are the things that we can correct with filler? First of all, it's important to tell your patient that this is just a camouflage. We can't reduce in any areas. We can only augment. And when we're augmenting, we're either trying to lift the nasal tip or to camouflage a hump or to augment a low dorsum to the nose. It's one of those three things typically. Occasionally, we'll be putting it on one side versus the other to make the nose look straighter. We're filling out a more concave side, and so those are some of the indications. So the first is to talk about the bridge of the nose. And if the bridge is low and we're not camouflaging a hump, we can usually inject the nose with a single injection point with a relatively tangential injection. However, if there is a big nasal hump and we're trying to camouflage that hump, it's difficult to navigate the hump with a straight needle or cannula. It's difficult to do a navigation of that. So we may have to stick in here and in here. So there are two ways that we're going to talk about the ways that we will infiltrate, and we'll also talk about the plane of infiltration. So in all instances, the plane of infiltration is deep to the nasal smaz. We've taken the skin off of the nose and we're staring at the nasal smaz, the musculature and the vessels that run on top of the musculature. And we can see the dorsal nasal artery here, the lateral nasal artery, which in this case is a branch of the infratrochlear. These lateral nasal arteries, which are the source of multiple skin complications, can be from variable arterial anatomy. And we don't really know underneath the skin what the actual anatomy is. But typically, there's an artery that runs right in the groove here, in the alar nasal groove. So there's an artery that runs right in that, and we want to avoid that. The second thing to realize is that the skin in the lower half of the nose is thick with dense fibrofatty tissue, and that has a little greater chance of a compartment syndrome. In both instances, we want to be deep to this nasal smaz. We want to be underneath of it. So our injection, whether it be with cannula or with needle, wants to be deep to the nasal smaz. Again, if there's a nasal hump, it may be difficult to navigate, so you may have to do an injection there and another perpendicular one up higher. It can be tangential, but this will be a perpendicular one where we'll be deep. And we're typically injecting this deep to the nasal smaz, getting rid of that hump by camouflaging it. If we want to lift the nasal tip, we also want a relatively deep injection. We would like an injection that is deep to the tip cartilages and goes just in front of the nasal septum. So if we look here, this is behind the cartilages, deep to the vasculature, and underneath this area. Lastly, we may put a deep injection along the nasal spine. That has to be deep. It should not be superficial, or else we'll get the columellar artery. So to lift the nasal tip, we may inject here or deep here. And both of those things will augment a tip. What I don't like is a superficial injection like this, right in the nasal tip, because that's where you can get congestion of this material, where there's a compartment syndrome and it's pushing in this dense fibrofatty tissue. So those are the hallmarks of injecting into the nose. We want to be deep. We would like to be in the midline to avoid the communicating arteries. On a rare occasion, we've got to be off the midline, and if you are, you should be deep. You should be underneath the nasal smaz. We're going to talk today about upper eyelid and brow injections. They're very different. Anatomically, they're different, and they do different things. The first is the deep to the brow injection. This injection gives the brow fullness, fills out the brow fat pad, and makes the brow look almost elevated in space, even though it's not a true brow lift. And in injecting the brow makes the brow appear as though it's had a lift. When we do this, we want to put our finger on the supraorbital rim. I'm feeling the rim. I'm feeling the bony rim. We want to inject superior to this and deeply right down on the bone. We'd like to know exactly where the supraorbital neurovascular bundle is and be lateral to it. But this is a deep injection that is right down on the bone, again, with the intent of pulling the brow away from the skull, filling out the brow fat pad, and making it fuller. That's as opposed to an upper eyelid sulcus injection. This is done for a hollower orbit and a hollow sulcus. The important landmarks of this are to know where the supratarsal crease is. I put a mark just where the supratarsal crease is. And now my injection is inferior to the bony rim. And it's not as deep because, of course, there's not bone underneath the rim. We're inferior to the rim. So the areas that I will inject are all along this area with very small aliquots, because the skin of the eyelid is very thin, and a contour deformity is very easy to do if you inject too much. Now sometimes the sulcus injection requires a medial injection. This is for the so-called A-frame deformity, when there may either be a senile A-frame deformity or an iatrogenic from previous surgery over resected fat A-frame. And this we're going to put on the medial side. Again, it's inferior to the orbital rim. Now, I've talked about where it is in a superior to inferior. That's inferior to the orbital rim. I like it just below the orbit and very clear of the sulcus. I want it much higher than the sulcus. I like to think that I'm filling from above down, from superior to inferior. I don't put it down here because this area of the skin is very thin and it's easier to see an injection, even though I'd like some fullness to spread down here. In terms of depth, this injection should be deep to the orbicularis oculi muscle and superficial to the levator aponeurosis. In other words, in front of, superficial to the fat of the upper eyelid, the deep fat of the upper eyelid. So in this dimension, the injection is just beneath the orbital rim, just inferior to the orbital rim. In this dimension, it's deep to the orbicularis and superficial to the levator aponeurosis. We're going to do the anatomy and show you that right now. We're describing a sulcus injection of the upper eyelid, which is performed for a hollowing of the upper eyelid. This is done for some patients that have a senile hollowing. This has just happened to them with age. They have a thin and recessed eye. And in other patients, they've had eyelid surgery or trauma and have recession and a deep sulcus.